5 years approximately. And the target of what's perio mission was in Egypt to focus on the perio as a specialty, to present the specialty as a key specialty among dental specialties. Many of the doctors and so many of the patients here can see the perio specialty is something which is concerned with just cleaning and polishing the teeth, no more. So we focus on this, and so we have to know if periodontology is concerned just only with that, or it is a deeper than that, or it is a key specialty interacting with other dental specialties. We present that through what's perio mission, through the courses we deliver from what's perio mission. We deliver basic periodontal courses and advanced periodontal courses regarding how to diagnose and treat any periodontal disease, about interactions with perio with other specialties, for example, perio-ortho, perio-restorative, perio-fixed, and perio-implant. And this is for 3 days. We have the first 2 days lectures, and the third day was a workshop, hands-on on cow or sheep heads. The second course, or the advanced course, or I call it Pink Smile Design course, it is talking about the role of perio in dental aesthetics. Nowadays, it is our concern, and it is demanding so much from the patient looking for veneers, looking for aesthetic restorations. We have to know if the dental aesthetics is concerned only with a white component, is concerned with how to make and prepare aesthetic restoration only, or there is another component which is not which is more important, which is more important, which is known as the pink component. So we discuss the role of perio in aesthetics. We discuss the main periodontal problems which can affect aesthetics. They are about 7 problems. And finally, at the end of the course, we talk about the prosthetic considerations in relation to the gingival, how to prepare aesthetic restoration, and how to fabricate the restoration without any destruction to the supporting structure, neither the gingiva nor the underlying supporting alveolar bone. This is for 3 days only. First 2 days lectures, and the third day, which is a workshop, hands-on on cow of sheep heads. This is a part of our workshops. As we see here, doctor training on the surgical techniques we teach and in the courses. And what I wanted to say is that what's perio mission, it is not in Alexandria only. It was traveling all over Arab Republic of Egypt to spread the word about the perio specialty, to focus on the importance of perio specialties among dental specialties. And to a great extent, thank God that I succeeded in that, and I am still ongoing on this mission. Now, let's talk about our topic today. This is the index of our lecture. We will discuss briefly a quick review of different types of gingival enlargement. Secondly, we will discuss the drugs which can affect the gingival size, which can increase the gingival size, which can cause drug-induced gingival enlargement, the double edge of the sword, in other words. And finally, we will discuss a case presentation of a case which came to our clinic and how we dealt with. First of all, for a better classification of gingival enlargement, we first to decide or determine this gingival enlargement is localized, concerned to interdental papilla, or concerned to free gingival margin, or concerned or diffuse, concerned to 2 interdental papillae and the free gingival margin, or generalized, which include 1 quadrant or more. Okay. Localized lesions, we can say in other words, they are known as the reactive lesions of the gingiva, which are lesions that arise as a reaction due to presence of local factors like plaque or calculus, which are very dangerous, which are so many, which are similar in all clinical features. So it is very difficult to differentiate between each one clinically. So the only way or the only solution to accurately diagnose this lesion, we have to make excisional biopsy. And under microscope, after histopathologic examination, we can say which lesion, biogenic granuloma, for example, or peripheral giant cell granuloma, or central giant cell granuloma, or whatever. It is very, very, very important to diagnose such case. We shouldn't neglect these lesions because they are very dangerous, as I said. Why? Some lesions may be benign lesions, and some lesions may be pre-malignant lesions, and some lesions we can find that it is metastatic lesion. This is lies here the importance of such lesions. Generalized gingival enlargement, actually there is not a single type of gingival enlargement. There are sub-classification here. We have inflammatory gingival enlargement that we all know due to presence of local factors, plaque and calculus, due to a bad oral hygiene, or it is idiopathic. As we know here, there is a gene that causes the gingival enlargement. It is away of the local factors. Or it is a conditioned enlargement, which means that it comes with systemic conditions or systemic diseases occurring in the human body, which is, or another one is the false enlargement. It is not an enlargement of the gingiva itself, but it is an overgrowth of the underlying structure. And finally, which we will discuss in full details in the case presentation, is a drug-induced gingival enlargement. Let's see some examples. This is the inflammatory gingival enlargement as we see in the right picture here due to bad oral hygiene, or we can see inflammatory gingival enlargement during orthodontic treatment, which is very common as brackets and wires and bands and the tubes. They are all plaque retentive factors. So if the patient doesn't follow the oral hygiene measures, gingiva can inflame easily. This plaque can accumulate easily, and the gingiva can inflame easily and so become edematous, as we see. Or inflammatory gingival enlargement due to a defective bridge or a defective restoration, due to there is an open margin or there an overhanging margin which cause the food impaction, which cause the gingiva to inflame. The other type, which is idiopathic, as we see here, it is very aggressive. Most of the teeth, anteriors and posteriors, are not appearing. It has a characteristic clinical pimpled surface, as we see, like as left picture here. There are blocks which are attached to each other, looks like this. Or a conditioned enlargement, and here there is a sub-classification too. There is maybe due to, or it is comes with hormonal changes which occurs during puberty or pregnancy, or it comes with nutritional deficiency like vitamin C deficiency, or it comes as an allergic reaction, allergic gingival enlargement, which is known in other words as plasma cell gingivitis, or finally, which is a very risky one, which come as a manifestation of a systemic disease, which is the leukemic gingival enlargement, and it is considered now one of the early signs of leukemia. As we see here, during hormonal changes during pregnancy, we can see a generalized gingival enlargement, or we can see a localized one, as we see in the left picture, which was known as pregnancy tumor, which is a mistaken nomenclature. Why? Because it is clinically and histologically a way to say It is a tumor. There is nothing to say it is a tumor clinically, and under microscope there is no tumor cells. So it is a mistaken nomenclature which is exchanged with another nomenclature with it known as pregnancy granuloma. Or we can say in generalized inflammatory gingival enlargement which occurs during puberty or during the adolescence stage. I wanted to say something here about the hormonal changes. Hormonal changes are not the cause of this enlargement, but there are risk factors. That means that if the patient has a very good oral hygiene during a pregnancy or during puberty, so there will not be an inflammatory gingival enlargement. But if there is a bad oral hygiene during pregnancy or during lactation, so hormonal changes occurs also in this stage, or during adolescence stage, so there is an inflammatory gingival enlargement. So it is only a risk factor, not a cause. During vitamin C deficiency, we can see the gingiva inflamed like this, and it has a characteristic feature that the gingiva looks like a fluid-filled sac or air-filled sac. And allergic, which is known allergic gingival enlargement or plasma cell gingivitis, this occurs due to allergen. For example, the patient uses a chewing gum, and after eating the chewing gum, the gingiva become inflamed and enlarged like this. It is very deceiving, by the way, because it looks like the inflammatory one, but with no local factors. With no local factors. Or they can use a specific toothpaste, which, for example, a herbal toothpaste, and after using this toothpaste, the patient said that there is a generalized gingival enlargement as we see. Or a lipstick for females, which touches the gingiva, and so the allergic reaction occurs. As a manifestation of a systemic disease, which looks like the idiopathic and so the drug-induced, as we will see after this case, which we can confirm it is leukemic or not by requesting a CBC, complete blood count, from the patient. We will see a very extremes. We will see extremes of increase in the number of white BCs, white blood cells. So we will refer the patient to an oncologist or hematologist, and he will perform other additional investigations to confirm if she is leukemic or he leukemic or not. False like this case. If we see here, you will see that the gingiva is normal in size. But the underlying structure, there is an overgrowth. There is an overgrowth in the underlying bone. There is a torus mandibularis, for example, like this case. And finally, we reach the drug-induced double-edged sword. Why we can say it is a double-edged sword? Some of the systemically delivered drugs, which can be used for certain indications, as we see, this is the good edge, and this is the good use of the drug. But there is a bad side effect. There is a bad edge of this sword, as we will see. These drugs are three categories of drugs: anticonvulsant or anti-epileptic drugs, immunosuppressive drugs or immunosuppressant. This is, we will see an example of the immunosuppressant as a case presentation in our lecture. And finally, calcium channel blockers. They can increase the gingival size aggressively to a degree that can affect the speech, and that can affect the mastication, and that can affect function of, and that can affect also aesthetics concerning the upper labial gingiva. This side effect will not appear on the gingiva after the drug intake after 1 week or 2 weeks. No, it will appear after 2 to 4 months of the drug intake. But what is the exact mechanism of this? How the drug can increase the gingival size? It's believed that this drug can cause a proliferation of the fibroblasts, which are found on the collagen fibers. It can cause their hypertrophy, and so the collagen fibers become enlarged in size, and so the periosteum itself become enlarged in size, and we see that clinically that the gingiva become enlarged. First example, we have the anticonvulsant drugs. One of the anticonvulsant drugs, they are not all causing this issue. One of the most common anticonvulsants which cause this, it is the phenytoin, dilantin, or in other words, tegretol, which are used to treat convulsions, which are used to treat epilepsy, as this case. We can say here that the gingiva is firm and resilient, and it is fibrous, and there is no signs of gingival inflammation despite this gingiva is enlarged, and it is enlarged aggressively here than the inflammatory gingival enlargement. This is one of the characteristic features that I can differentiate it between inflammatory and between the drug-induced, but it is very difficult to differentiate between the three drugs. I cannot say clinically this is due to antiepileptic, or this is due to immunosuppressant, or this is due to calcium channel blocker. The only way, when I am taking the drug history from the patient said that I take tegretol or phenytoin, so this is drug-induced gingival enlargement due to the use of tegretol. The second group, which are the calcium channel blockers, not all the calcium channel blockers, by the way, cause this problem, but there are two main types of the calcium channel, or two main categories of the calcium channel blockers which can cause this. It's the nifedipine and the amlodipine. As we see here, it is very similar to the last one. As we say that we cannot differentiate between them clinically. And it is scattered, as we know, labially, lingually, palatally, and in some cases it can extend to the occlusal surface, and this can become lacerated and become inflamed when the patient bite and when the patient try to eat. Immunosuppressive drugs, which are not all causing this issue also, but there is a certain drug which is the cyclosporine. There was another one which is known as atacrolimus, but recently, and the recent studies confirmed that it had no effect on the gingiva. The only one among the immunosuppressive drugs which can affect the gingiva aggressively, which is the cyclosporine, which is the most powerful one, which all the physicians prefer to prescribe to the patient. But the question is here, why I prescribe the immunosuppressive drug to the patient? And here lies accurately the double-edged sword. I prescribe the immunosuppressive drug to the patient in two cases. When the patient has an autoimmune disease, in this case, the immune system got crazy. The immune system is trying to attack its own organs. It considered them as antigens, foreign bodies, so it began to attack. So you have to suppress the immune response. This will not occur without the use of the immunosuppressive. The other case, we can use the immunosuppressive drug cyclosporine in case of organ transplant. After organ transplant, the patient must, not should, the patient must take this drug forever, as also the immune system doesn't believe that the transplanted organ is a kidney, for example. It is not a kidney. The immune system say it is not a kidney. It is a foreign body for me, so I will begin to attack it. So to prevent the immune system to attack, we have to guard this organ We will not guard this organ without the use of cyclosporine. So this is a good edge and to protect the organ by the drug, but the bad edge, it had our side effect here. As we see, the teeth are completely obliterated or covered by the gingiva upper and lower, as we see labial, as we will see in the second picture, in the second slide, palatal and lingual. And we can say, or we can, see here that the gingiva has a mixed color. There is a pink color, and here the gingiva is lacerated and inflamed. This is occurs why? Because the gingiva, when become enlarged, the orifice of the gingival sulcus start to increase. So this space start to become very wide. The space become very wide, so food impaction will be more easy. It will be easier, and food impaction can occur rapidly. So the gingiva become start to inflame, and so had this this color. So we can say here there is a mixed enlargement. Mixed enlargement, that means that the enlargement here is inflammatory plus drug-induced. Drug-induced gingival enlargement, and the effect is ongoing, and so the gingival sulcus become widened, and so food impaction occurs, and so the gingiva inflamed, so it has become inflammatory at last. This will accelerate the progression of the gingival enlargement. This is very clear here in the left picture. As we see here, there is a very big space between the lingual gingiva and the crown, and we will see here there is a calculus. And the gingiva opposite to the calculus for sure is inflamed and lacerated. And it is very clear here in the upper, but I think it is more in the lower. Okay. Now you have to discuss our case presentation. We know the cause and we know what is meant by the double-edged sword. Let's see how can we put a very accurate treatment protocol for such cases. This case, as we saw, is a male patient, 40 years old. He is a surgeon, general surgeon, come to our clinic presenting with severe gingival enlargement confined to the upper and the lower anteriors, invading the labial, palatal, and the lingual gingiva, as we see here. The patient told us that he is under immunosuppressive drugs since 1 year. That means that he made the organ transplant surgery since 1 year. And he said a very important point, that he doesn't neglect his oral hygiene. He didn't neglect his oral hygiene. He tried to use the brush and to use the interdental brush and use to floss, but with no effect. Food impaction is still ongoing with no effect, and the gingiva is ongoing in its enlargement, and it is increasing aggressively and progressively. He said that he went to many doctors to treat this case, but every doctor said to him that this will recur. If I made any step regarding your case, it will recur. This is a very common word that he heard from them. So at last he came to our clinic by referral from a colleague to see if there is a solution. The patient here is psychologically and functionally in a very big problem. He doesn't eat perfectly, and the food impaction comes easily, as we see here. He didn't smile since 1 year comfortably, in a comfortable way. This is a very big problem for him. There is a food impaction occurs ongoing with non-stop, and he cannot smile in a very comfortable way as before he performed the organ transplant. So we have to try to find a solution for such a patient. As we see here, this is not the smile of the patient. This is the rest position of the patient. The patient told us that during this position there is a lip seal, which is, as we know, it is the normal condition, okay, which is we can see there is a lip competence. But here, due to the severe enlargement of the labial gingiva, the gingiva push the upper lip forward, so he cannot make the lip seal as before. Okay, here is the problem during the smile. The gingiva appears in front of anyone that it is enlarged, which caused to him some sort of impressment. And so this caused a very bad problem. This caused another problem, which is that during sleep he become a mouse breather. He can't make the lip seal. Okay, so this part of the gingiva is exposed to air, so it become dry. Alternate drying and wetting of the gingiva can cause the gingiva to inflame. And so the size of the gingiva is aggressively increasing. So it is another factor which can help to increase the gingival size. We will decide at first to make full mouth scaling and root planning to remove all the microbial load he had, to remove all plaque and the calculus, to remove all the laceration we had. This will not decrease the gingiva to a great extent, but we will have to improve the oral hygiene as much. We had to improve the oral hygiene as much as we can. We had a consultation with his physician if there is any possibility to exchange the cyclosporine with other immunosuppressive drug other than the cyclosporine, and he refused as the condition of the systemic condition of the patient necessitates the use of cyclosporine. So we have to deal with cyclosporine. There is no way. The above photo is by 3 sessions of scaling and curettage. Between each session, 1 week. This is after 3 weeks. As we see here that the gingiva decreased in the size. We had some gingival shrinkage, but we are not expecting to a great extent, as I said. Here also to the lingual gingiva, there is a very big decrease, but it is still enlarged. But at least we transformed the mixed gingival enlargement to a drug-induced gingival enlargement. Okay. This is another photo which is more clear, revealing the gingival size labially and lingually after complete scaling and curettage. And this is for the upper. The below photo is after scaling and curettage. We got some sort of gingival shrinkage also. And the palatal, the below photo, it has become more fibrous and it decreased a little bit. We decided to perform gingivectomy for upper and lower, labial and lingual and labial and palatal and lingual. Why we will make gingivectomy? To improve the oral hygiene of the patients, because the oral hygiene measures he followed had no effect. So we have to improve the oral hygiene as much as we can. But what about the recurrence? We will see this at last. Okay, we decided to make the surgery But before we performed the surgery, we had to make another consultation with the treating physician, as we wanted to know in which stage the organ transplant. We have three stages: an immediate post transplantation stage, and there is the stable post transplantation stage. In the immediate one, which is after 1 or 2 or 3 months of the organ transplant, the patient here is severely immunocompromised. By the way, this drug is an immunosuppressant, so this patient is immunocompromised. He is considered an immunocompromised patient. So, as an immunocompromised patient, we had to give, or we have to prescribe, a prophylactic antibiotic before the surgery, 5 days before the surgery. Any antimicrobial containing, for example, amoxicillin. Okay, this is one of the recommendations of the physician. There is another recommendation: after surgery, you have not to prescribe non-steroidal anti-inflammatory drugs and erythromycin, which is an antimicrobial. Why? Because it was found that non-steroidal anti-inflammatory drugs and erythromycin can decrease the level of the cyclosporine in serum. It can increase the serum level of the cyclosporine, which can lead the graft to reject, which can lead the organ to reject. As we decrease the level of cyclosporine, the immune system will start to observe, or will start to see the organ, and so it will begin to attack. Okay. Any surgery we perform, we have to make CBC, complete blood count, bleeding, clotting time, and INR, which measures the bleeding tendency, and which is the international normalized ratio. And the values were within normal. So we prescribed the antimicrobial 5 days, and after the 5 days, the patient come to us, and we performed the first surgery. First surgery, we performed the lower gingivectomy concerning the labial gingiva and the lingual gingiva, and after 2 weeks, we performed the upper labial gingivectomy for the upper labial gingiva and the upper palatal gingiva. We will see now step by step. This is the baseline photo as we saw before. We will start to perform infiltration anesthesia labially and so lingually. There is no need to bilateral nerve block here. Only infiltration anesthesia is enough and sufficient. We distribute the infiltration anesthesia to the quadrant, from distal to the left canine to the distal of the right canine. And so the lingual infiltration. And here it comes a very big challenge. The gingiva here had a very deep gingival clefts, and the gingiva here is almost completely detached from the tooth. As we know, for the guidelines of the external bevel gingivectomy, I will stop here. As we all know, for the guidelines of the external bevel gingivectomy, that we determine the zenith point or the bleeding points guided by the probing depths. But there is a very big problem here. What is this? If we followed the probing depths here, and we measured we determined the bleeding points here, we will end with a gingival recession. We will end with a gingival recession due to a very deep gingival clefts which were found here. So we have to look for another reference point for the zenith point. So we have no reference point other than to determine the zenith point to be opposite to the CEJ, to be opposite to the cervical line, to be opposite to the cement to enamel junction. Because the reference point guided by probing depths may end up with a defect here, which may end up with a gingival recession. As we see, due to the very big detachment here, we can see the root surface as we see here. Okay, I determined the first bleeding points guided by reference point, our new reference point, the CEJ. And so for the lateral, centrals, and through the canine. The challenge here also that the surface of the gingiva is not regular, it is irregular due to the presence of many gingival clefts, which make the surgery more difficult. Now we will start to draw the incision line, guided by the zenith points which I determined. This is my limit for gingivectomy. I should put the plate or the laser tip anyway on this line, not too much coronal and not too much apical. I am trying to draw the line as much as I can. This is difficult due to the irregular surface of the gingiva, as I said. After I finish drawing the incision line to reaching the right canine, I will start with external bevel gingivectomy, starting from the left canine. Here, as we say here. As we all know that we make the external bevel gingivectomy, it should be with bevel. It should be, the blade should be angulated 45 degrees to the longer axis of the teeth to get the knife edge shape of the gingiva. If we place or if we direct the blade 90 degrees to the longer axis, it will result in a shelf, which is functionally and aesthetically not acceptable. We may start tooth by tooth, or we can make external bevel gingivectomy in the whole quadrant and start to exercise. We have started to exercise tooth by tooth. The canine is almost finished. And we reach it here, the interdental papilla between the central and lateral. In a normal fibrous gingival enlargement, which we can get after polyscaling and curettage of an inflammatory gingival enlargement, the surface of the gingiva is regular, so we can exercise the gingival margin, which is the enlarged as the one piece. But it is very difficult here because it is clefted, as we see. So there are exercised tissue by tissue, or in two pieces, as we see. So this make the surgery longer. Okay, here it comes, this enlarged papilla. If I make external bevel gingivectomy starting from here with a very deep cut to exercise the enlarged papilla, I will end with a very big space here between the central and the lateral. So with a very big enlarged papilla as this papilla, and so the other one between the canine and the lateral, or sorry, between the central and the lateral, we can exercise the gingiva in two steps. First step, we will make de-epithelialization of the enlarged papilla. We will make the de-epithelialization to decrease the gingival size. We are not exercising here. We are de-epithelize. We make de-epithelialization. We only remove the outer surface. This will help to decrease, and this will help to determine where I will make my gingivectomy. Where I will make my deep cut. Where I will locate my new interdental papilla. I will perform such procedure here also between the right central and right lateral. I made the de-epithelialization first. Then I will finalize with gingivectomy, as we see here. This is a motion, as we call shaving motion. This is a gingivoplasty. We reshape the gingiva in cases that the gingival margin, we didn't get the knife edge shape as we want. So in thick margins, we make shaving motion to make thinning of the gingival margin. Okay, let's continue like this. After I completed the labial gingiva, I started the lingual one. And here the thinnest points also, the reference point here is the CAGL, cervical line, as due to presence of deep gingival clefts also lingually. The same as the labial. After I made gingivectomy, there are a very deep calculus deposits which were embedded subgingival. Although that I made this step, which the scaling by ultrasonic scaler in the first session, but some calculus deposits were not appearing; they were embedded subgingival, as we see here. It was appearing now, so I have to perform another scaling. If I left the calculus deposits, this will compromise for sure the healing. So I make sure that nothing is interfering the healing. I almost finished labial and lingual. We will see now a final photo after finishing the procedure. As we see here, the labial, and we will see also the lingual. We tried as much as we can to return to the normal gingival size, labially and lingually. It is recommended after I finished my procedure to put a periodontal dressing, which is known as the perio pack, which is a zinc oxide non-agenol pack, two pastes, base and catalyst mixed together, and I should wet my hand to avoid attachment of the pack to my hand, and then I roll it and make to insert the perio pack in the gingival, on the interdental embragures to make a mechanical lock. Within 10 to 15 minutes, it will sit. It will be here till the first week. When the patient come for follow-up, I will remove the perio pack. It will be very hard. It will be removed by a tissue forceps or a tweezer as a one piece. And here I put one labial and another one lingual. We have to take care that any high points should be removed like this. I have to remove this so it will not interfere with the centric relation of the patient. Let's see the result after 2 weeks. This is a picture after 2 weeks. As we see here, the below photo. And let's see lingual. This is lingual, the above photo. After we finished the lower quadrant, we proceed to the upper one. Sorry. The upper was much more easier than the lower because there were no the gingival clefts as we saw in the lower labial and the lingual gingiva. So here we determined the thinnest points guided by the probing depths as the usual one, as the usual gingival enlargement we face. And so for the palatal, we make infiltration anesthesia labial and so palatal in the incisive papilla and infiltration also. We determine here the zenith points in the upper anteriors as it is an aesthetic zone. We determine the bleeding points or the zenith points guided by probing depths, but with respect to the gingival harmony. As we all know from smile designs that gingival margins should be in harmony with each other. The zenith points of the canines, for example, and the centrals should be in the same line, while the laterals should be coronal to centrals and the canine with 2 millimeters. So we have to put this into considerations while determining the zenith points. I made the probe in a horizontal direction like this to adjust the harmony. To adjust the central to be apical than the lateral by 2 millimeters. You have to adjust also the left central to be in the same line also with the right central. And so the canine as you see here now, in the same line. I am starting now to draw the incision line. It's much more easier also here because the surface of the gingiva is much more regular than the lower one, because there are no clefts like the lower one. And then I started to make the external bevel gingivectomy, which is also much more easier than the lower, and to a great extent I exercised the enlarged gingival margin as a one piece, which is much more better to get even shape and thickness of the new gingival margin. As much as I can, I have to make this during my surgery. I have to exercise the gingival margin as a one piece as much as I can. I continued to the other teeth. And let's see the photo after I finished. I finalize here. And I made the shaving motion also here, as some gingival margins are thick. I have to make them all knife edge thin, which is accepted functionally and aesthetically. Functionally, to avoid food impaction, as the gingival shelf will be a very good area or place for food impaction. Aesthetically, it will the knife edge shape, it will give a more aesthetic appearance for sure. As we see here. Then I proceeded to the palatal one. The same, the thinnest points are guided by the bleeding points, or the thinnest points guided by the probing depths. As we all know here, the palatal is much more fibrous and much more resilient, and so resistant and more bloody. The difficulty here, when I made the palatal gingivectomy, that it's continuous with the labial due to open embrasures, due to multiple diastemas we have here. It's continuous with the interdental papilla labial. I almost finished. This is the final picture after I finished the palatal one, as we see here. And so I put periopack, labial, and palatal, and then after 2 weeks I removed them. And let's see the healing after 2 weeks. This is a labial, as we see here. We're returning the gingiva to the normal size as much as we can. And let's see the palatal also. And let's see the smile of the patient. This is now the actual smile of the patient. He can smile now confidently with no any embarrassment as before. By the way, there is no now a mouse breathing habit, because the gingiva or the labial gingiva returned to its normal size. Okay. Do we think that we finished this case by these two steps, the upper gingivectomy and the lower gingivectomy? No. The upcoming part, it's the more important part, which is a strict follow-up. To maintain the gingival size to a degree that we will not perform another gingivectomy, we have to make the following. First one, we have to make the patient to follow a strict oral hygiene measures regarding the flossing and the brushing techniques 2 or 3 times per day with the proper brushing or flossing technique, as we all know. And also we have to make follow-up every 3 months or every 1 month to check the gingival size, to check any gingival inflammation, to begin with treatment of any periodontal disease as soon as possible. As we all know, any inflammatory condition with the drug, it will accelerate the gingival enlargement, as we saw before. So if we make this for a very long period, we will see this photo. This is the photo after 1 year follow-up. I am very sorry for the quality because it is by the patient's camera because he couldn't come to our clinic in this day. So he made the photo as much as we can. But as we see, this is after 1 year follow-up. This is a very good one. There is no recurrence. So the drug is not the only thing or the only factor which is guilty about or concerning the gingival enlargement. No, but the local factors which accelerate the progression, the local factors which accelerate the occurrence of the gingival enlargement, the local factors that any doctor of the doctors he went to didn't deal with. All the doctors he visited didn't at least make scaling and curettage to control the inflammatory problem, to control the periodontal disease. And so the progression is ongoing progressively. The condition is ongoing progressively. And this patient, by the way, is still with follow up with us till now. There is no stop. There is no stop as he is taking the drug, and we all know that it is a lifelong drug. The physician refused to exchange it. Final case we have also with a drug-induced gingival enlargement. Sorry. This is also with a 30 years old male patient that he had organ transplant since 6 months, as we see here. Here the patient is taking cyclosporine and is taking nifedipine, which is a calcium channel blocker. So we have now two drugs causing the drug-induced gingival enlargement. And so due to the effect of the drug, the orifice, as we all know, become widened, and so the inflammatory problem begins. And so progression occurs more, or sorry, it's become more accelerated. We followed the same protocol regarding scaling, regarding curettage, as we see here is a photo after 3 weeks, some sort of shrinkage as we all saw in the previous case, and then we performed the gingivectomy. But here the degree of the gingival enlargement, as we saw, it is much more, or sorry, it is better than the other case, or because it was smaller than the better case, the last case to a great extent. This is due to the period. This occurs after 6 months, while the last case it is after 1 year. So it become progressively enlarged. We had the same gingivectomy here. We followed the usual guidelines of the bleeding points concerning the probing depths with respect to the gingival harmony labially. So it was very easy, like any usual gingivectomy for an inflammatory gingival enlargement. So let's see the final result. This is the photo after we completed the procedure, labial and palatal, and so periopac, labial and palatal. This is after 1 week. 50% healing. It's not yet full, completely healed here by the second week. Labial and palatal, and we had the same protocol regarding the follow-up. It is much more easier than the first part. The second part is, as it's much more important than the first part. Okay? Here there is a very good advantage regarding the use of nifedipine that we requested from the physician to exchange the nifedipine with another antihypertensive drugs يعني, other than the nifedipine, and he accepted that. So he is no longer taking now nifedipine. He is taking also only the cyclosporine, like the previous case. This is my sources for What's Perio. This is What's Perio Academy, which is a group discussing all the case presentations and all case studies regarding periodontology. This is the second page, which is What's Perio courses, concerning the announcement of courses organized by What's Perio team or by other organizers. This is What's Perio gallery concerning all the cases and the surgeries I performed with full case presentations. And at last, What's Perio YouTube channel, which had my videos of my perio surgeries. At last, I would like to thank you. I hope that my presentation was interesting to you. I hope that my treatment protocol is a very good thing for the patient. I hope that this is we can follow with such a patient by the personal experience or by the personal experiment. It is very beneficial up till now. But the solution is not to leave the patient. The solution is not to say to the patient that it will recur, so I will have to do nothing. Okay? Very much thanks. I hope that was interesting, and I will start to answer any questions. Thank you.
Thank you, Doctor. Your presentation was both interesting and impressive. You took us through the subject step by step, and it was a smooth ride. I think anyone watching would agree. So, thank you for including the videos and the sources too. Your practical approach is going to be useful for many, I'm certain.
Thank
Uh,
you, Dr. Nada.
can I ask you, what do you do with all the tissue you remove? Is it useful after that?
Some doctors make biopsy for these tissues to see what is the main effect of the drug. But we will see proliferation just of the fibroblast. We will see a fibrous overgrowth, just no more. But I think there is no need to make the biopsy. Only in one condition we can make the biopsy, when we don't know the exact cause of this enlargement. We don't
Okay.
know the exact cause of this, but we know before we diagnosed
Yeah.
the case, and so we make gingivectomy. Okay, so there is no need
Yeah.
for biopsy.
Okay, thank you. There's a question again. Could you tell us more about the periodontal manifestations of some systemic diseases, and ultimately how the dentist could play a part in early diagnosis of the said disease? That looks like a loaded question.
Very loaded. I will talk about the most important that we face in our dental clinic. So I will talk, for example, about the leukemic one, because it is much more important, and we face nowadays a lot of cases. We can see a bleeding gingiva with no exact cause. The gingiva can bleed when it become inflamed. We will see an inflamed gingiva, and it sees that it can bleed spontaneously without any provocation, without any probe that we place in the gingival sulcus. This is unusual. This make a suspicion for something like leukemia or bleeding disorders. For example, hemophilia. For example, it one of the manifestations that the gingiva can bleed easily. How can bleed unusually? So if we make a very deep subgingival restoration and there is a gingival bleeding, the bleeding wi- doesn't stop other than I can use a local hemostatic measure. That's that ma- that makes that there is something wrong with the patient. First of all, I will make CBC, so it will reveal if the patient as a bleeding disorder. There is a defect in the number of the platelets. There is a decrease in the number of the platelets, or it is anemic. It can have the same manifestations also, تمام? Or it is leukemic. There is a bleeding disorders also with leukemic patients. And we make another confirmatory the investigations regarding bleeding and the clotting time, and the values will become not normal. Okay.
Okay, thank you. There's also another question. What are the functions of the perio pack that you were using, I guess, in the
Okay.
presentation?
Periobact act as a dressing to protect the wound from contamination, to promote healing, no more. We can make there are many alternatives for the periodontal dressing. If I don't have in my clinic, we can use gingival gel, which is a hyaluronic acid gel, to apply on the wound 2 times per day for 2 weeks. This will accelerate healing.
Okay.
Periopack Periopack, by the way, it should be removed after 1 week. Otherwise, it will be plaque retentive. It will have a gap between it and between the gingiva. So it can make a
Yeah,
food infection. There is no
that
need to put it more than 1 week. Okay.
yes, that makes sense. I'm gonna see if there are any more questions. Oh, okay. Can you read this one?
Yes.
There has been some talk about a link between Alzheimer's disease and periodontitis. Is this something you're familiar with? And if so, what's your take on that?
Yes, there is a very good link, and there are too many studies for this. To make it easy and simple, I will say that the bacteria of the periodontal disease, it will release a protein. Okay, this protein will precipitate on the brain. It was found that this protein, when it precipitated in the brain, it became one of the risk factors to provoke Alzheimer's disease. It is not a cause; it is a risk factor.
Okay,
So
that's
there is
interesting.
should be a very good awareness of the good oral hygiene regarding Alzheimer patients for sure, to prevent the progression of the disease. There is a very good link between the periodontal disease and the many systemic conditions, by the many systemic disease, by the way. There is a vice there is a vice versa reaction. There is a two-way reaction. Either the periodontal disease can accelerate the systemic disease, or either the systemic disease can accelerate the periodontal disease itself. Okay.
And that's really interesting. Thank you.
You are welcome, Dr. Mercy.
Je ne sais pas si tu pourrais lui poser une question. C'est le rôle du laser dans la chirurgie et dans le laser diode dans la chirurgie des hyperplasies et la biostimulation pour aider à la guérison de la gencive.
Okay, so someone is asking, what's the role of laser in periodontal surgery of hy- hyperplasia, I think? C'est quoi la suite de la question?
Et son rôle dans la biostimulation, dans la guérison de la gencive.
Okay, and the role of laser in healing of the gums.
For sure, for such cases that I performed with the blade, the laser will be the most minimally invasive one. Less bleeding, faster healing, better coagulation, for sure. Laser, we have two types of laser, as we all know: surgical laser and non-surgical laser. Non-surgical laser is used to a great extent in the treatment of periodontal pockets. It can be used instead of locally delivered drugs or systemically delivered drugs after complete curettage of the pocket. It will have the same rule of the systemically delivered drugs or the locally delivered one, to make disinfection of the pocket to promote the healing. For surgery, surgical lasers like carbon dioxide, ND laser, whatever. It's perform. We can perform gingivectomy. We can perform crown lengthening. We can either perform frenectomy. The main benefits of the laser in surgery is the faster coagulation, so faster healing. By the way, we don't need the perio pack when we make the surgery with the laser because the healing it's much more faster. Okay,
Okay, thank you.
or have I have to become more clear, or it is okay?
No, it's okay.
I think
Okay,
it's okay.
Thank you.
okay.
Do you give special recommendations to your patients after the surgery or before the surgery? Do you put them on medication?
As we said before the surgery, for such patients as they are immunocompromised, for
Yeah.
sure we have to prescribe a prophylactic antibiotic 5 days before the surgery, and this antibiotic will continue after. Okay, and after the surgery, in addition to the antimicrobial, we prescribe anti-edematous drug like anything contains alpha chymotrypsin 2 days per day before each meal for half an hour. And we can prescribe any non-steroid and anti-inflammatory drugs if the patient it is not contraindicated for him or her. To accelerate the healing, if there is a perio pack, after removal of the perio pack in the second week, we prescribe to the patient a gel, which is hyaluronic acid gel, to put on the wound 2 times per day for 2 weeks to promote healing, and use any chlorhexidine mouthwash, but without dilution. 2 times per day without dilution. Yani it's become concentrated. This is our recommendation for the patient.
Thank you very much. This was very comprehensive.
Okay.
This
Je
is
tiens,
our actual protocol since years.
je tiens à vous remercier, docteur Mina Saad. Je ne sais pas si je peux parler en français.
Diria
Vous
doctor,
comprenez?
doctor, Diria doctor, sorry.
D'accord. Donc, je tiens à vous remercier pour la qualité de votre présentation. Et vous serez toujours le bienvenu sur Tawassul et au Maroc, bien sûr. C'est votre deuxième pays, j'espère. Docteur Nadal Hamid, je tiens à vous remercier pour votre participation. Et merci encore, vous êtes chez vous. Pas besoin de vous accueillir chez vous.
C'est avec grand plaisir.
Merci aux membres de Tawassul. Sans vous, sans vos encouragements, Tawassul ne serait pas la plateforme qu'elle est maintenant. Je tiens à remercier surtout les partenaires qui nous aident à améliorer la qualité du travail de Tawassul. La conférence a été en anglais. The last but not least, les membres de la direction de Tawassul qui fournissent énormément d'efforts pour un travail, pour montrer que Tawassul peut faire maximum de. Le mot de la fin à vous, Dr Nadal Hamid et Dr Mina Saad.
Merci beaucoup. I don't know if I need to translate to you,
Non,
Dr.
non.
Mina.
Il comprend le français, je
For
crois.
sure. I am waiting.
À vous.
Well, personally, all I can say is thank you. This was really interesting, and I read some of your work on my Zerodonto, and it was a pleasure to read it. So thank you for posting it. Thank you for sharing your knowledge.
You're
That's all
welcome,
I can
doctor.
say.
For sure, this case presentation were found for yes on the redont. You're welcome, dear Doctors Nada, dear Dr. Karim. I am very thankful to all of you to let me this precious opportunity to present my webinar, and I hope was really interesting to you. Very much thanks to all of you, and send my warmest regards to Dr. Ali.
I think he hears you downstairs.
Okay.
Merci, docteur.
ميرسي دكتور، شكرا.